안녕하십니까. 이번 시간에는 소아에 관한 토픽 두 개를 강연하실 분을 소개드리겠습니다. 이 하지메 아라이 교수는 지금 현재 준텐도 유니버시티에 근무하고 계십니다. 과장 주임 교수로 계십니다. 이분은 뭐 거기에 잘 적혀 있기 때문에 더 디테일하게는 이야기 드리지 않겠고, 이번에 바로 전님 과장이 기요시 사토라고 아주 활동이 대단히 많으시던 분이고, 그 위에가 이시 선생님이셨습니다. 그래서 아마 이분이 준텐도 유니버시티 디파트먼트 오브 뉴로서저리의 세 번째 제가 아마 지금 현재 과장이시고 그렇습니다. 이분의 커리어 중에서 보면은 미국에서 펠로십을 할 때 NIH에서 이 뉴로 케미스트리에 대해서 공부를 하시고, 바이오 케미스트리, 뉴로 케미스트리 여기에 상당히 관심이 많고 거기에 대한 리서치를 하시는 거로 되어 있습니다. 그러면서 클리니컬 액티비티도 하시고, 오늘 이 발표할 라이프 마케이션은 이미 2001년도에 그 대학 준텐도에서 120 케이스를 갖고 퍼블리시를 한 그게 과거 페이퍼가 있습니다. 그래서 오늘 말씀해 주실 분야는 하나는 엔도스코피고, 두 번째는 이 라이포마에 대한 상당한 경험이 계신 분이니까 좋은 강연이 될 것으로 생각이 됩니다. 예, 프로페서 이시, 프로페서 아라이.
Thank you very much, Dr. Cho. It is my great honor and pleasure to be here. I express my thanks to Dr. John and other staff of Seoul National University. Today, I would like to present my experience of a neuroendoscopic surgery in a pediatric patient. The neuroendoscopy can be used for endoscopically assisted microneurosurgery and neuroendoscopy thorough surgery. I think the rule of neuroendoscopy thorough surgery is greater in the pediatric patient group. This afternoon, I would like to talk about the endoscopic third ventriculostomy for hydrocephalus, endoscopic management of arachoidal cyst, and endoscopic management of intraventricular tumors. There are several key points in the endoscopic third ventriculostomy. The standard frontal bar hole is made just before the coronal suture and 3 centimeter from midline. This gives the best trajectory into the lateral ventricle. And endoscopy introduces lateral ventricle and the third ventricle through the foramen Monro. And a hole is made in the thin third ventricle floor just behind the infundibular recess here. I don't like use any coagulation device to make a hole in the third ventricle floor. And it is important to make a hole in the third ventricle in direction to the dorsum dere to avoid injury of a basilar artery and its branches. And finally, the hole is enlarged using a balloon catheter. There are several facts which is generally accepted regarding effectiveness of endoscopic third ventriculostomy. Late onset aqueductal stenosis effective. Infants with aqueductal stenosis may not work. Newborns with myelomeningocele or with intraventricular hemorrhage not effective. Older children with myelomeningocele effective in 50% of patients. Previous shunting procedure not contraindication. and acute management of hydrocephalus in association with a posterior fossa tumor effective. The ideal candidate for third ventricle stomy is a patient with adolescent or adult onset non-tumor aqueductal stenosis. They respond with a success rate of almost 90%. Regarding an indication of a third ventricle stomy, we have to consider the several points. Type of hydrocephalus. Of course, the third ventricle stomy limit to a patient with a non-communicating hydrocephalus. But indication for the etiology unknown hydrocephalus, such as the hydrocephalus with the spina bifida, is a matter should be discussed. Patient age. Some authors indicate the good result in the patient over the 2 years of age, but poor result in the patient under 6 months of age. Patent subarachnoid space and normal ability of CS absorption are necessary condition for third ventricle stomy, but problem is how to know these factors. CT cystoscopy and outflow resistance with the ICP monitoring may be helpful to assess these factors, but not definite. Another thing is that we have to realize that these factors are changeable with aging. So we did endoscopic third ventricle stomy in 120 patients. The 29 cases have a history of previous shunt placement. And we define being a shunt independent for 6 months as a successful third ventricle stomy. And this is the result. In the patient with aqueductal stenosis, the success rate is 75%. Hydrocephalus with myelomeningocele, 47%. Posterior fossa tumor, 100%. And total success rate of endoscopic third ventricle stomy amount to 73%. This is a summary of the success rate in the literature. The etiology of hydrocephalus vary in this report, but our result, 73% of success rate, is fairly acceptable. And if you look at the patient under the 6 months of age, in a patient with the aqueductal stenosis, success rate is 75%. And this patient, post-meningitic hydrocephalus, MRI showed the ventricular dilatation, so that we try to do endoscopic third ventricle stomy, but it was failed. And if you look at the patient from 6 months to 2 years of age, in the patient with the aqueductal stenosis, success rate is 100%. So that from our experience, I think that the endoscopic third ventricle stomy can be a choice of treatment for aqueductal stenosis, even in neonates and infants. Various complications have been reported associated with the endoscopic third ventricle stomy. Fortunately, you have no complication in our series. But the problem is failure of endoscopic third ventricle stomy. We have 9 cases of early failure in whom the endoscopic third ventricle stomy was failed within one postoperative month. These failures must be related to etiology of hydrocephalus and or patient age. On the other hand, in delayed failure, in this patient, the third ventriculostomy had functioned for a certain period after the surgery, but the stoma was obstructed due to a proliferation of gliotic tissue and arachnoid membrane. I want to show you the one instructive case. This is a 7-year-old girl with aqueductal stenosis. She had a history of a previous VP shunt and multiple shunt malfunction. He came us with a shunt malfunction, and we did a third ventriculostomy, and the preoperative MRI indicated the enlargement of ventricle and downward displacement of a third ventricle floor here. And after the operation, we can see a flattening of a third ventricle floor and a floor void at the third ventricle floor. 1 year, 6 months later, the MRI was performed, and we saw the downward displacement of third ventricle in some extent. But the patient condition is fine, and we can see some to and fro movement at the floor of third ventricle at this time. So that we decided the patient follow up in outpatient clinic. But 5 months later, the patient suddenly became a comatose state, and we did extraventricular drainage and third ventriculostomy and VP shunt. But the patient never recovered and became a vegetable state. And what we found is the obstruction of a stoma. So that I want to stress that the obstruction of a stoma can occur anytime after the endoscopic third ventriculostomy. So that meticulous follow-up observation is mandatory for patient with the third ventriculostomy. I want to move to arachnoid cyst. Our experience is 24 cases, including the 7 cases of middle fossa cyst, 8 cases of suprasellar cyst. During a period from late 80s to early 90s, we put CP shunt on arachnoid cyst without exception. And this is a summary of our experience of 77 cases of middle fossa arachnoid cyst surgically treated with a CP shunt. And what we found in these 7 cases, chronological CT scans after surgery show the re-expansion of a surrounding brain and the disappearance of the cyst in all cases. And the most clinical symptoms and signs improved post-operatively with the disappearance of a cyst. And there are several types of complication, and including the complication related to the shunt placement. I would like pointed out these 4 cases, shunt dependency. 4 of 77 patients present acute signs and symptoms of intracranial hypertension when the shunt malfunctioned, although the concurrent increase in the cyst size was slight and ventriculomegaly was not seen. This is an example. Such a large middle fossa arachnoid cyst was treated by CP shunt. The 1 year post-op, cyst almost disappeared. And when the shunt was malfunctioned, the patient showed the sign of increase in intracranial pressure, although the concurrent increase in the cyst size was very much slight. And shunt was replaced and the symptom was gone. So this type of phenomenon must be related to the the loss of elasticity of brain, such as a slit-like ventricle syndrome. On the basis of experience of such a shunt dependency in patients with a CP shunt, we adopted the endoscopic cystocystinostomy for arachnoid cyst. This is a middle fossa arachnoid cyst. The endoscopy was introduced within the cyst, and the fenestration was made in the membrane, and post-operative 6 months, the cyst was disappeared. This is a case of a bilateral CP angle arachnoid cyst. Such a lesion could be treated nicely using the endoscopy, endoscopic cystocystinostomy. And this is a summary of our cases. Satisfactory cyst reduction and clinical improvement were achieved in the 22 cases. So that I think the endoscopic cystocystinostomy can be a choice of a treatment for arachnoid cyst. As I showing you, the endoscopy is useful in treatment of arachnoid cyst. And it also gives a new concept to help us to understand pathogenesis of arachnoid cyst. I want to discuss a possible etiology of a suprasellar arachnoid cyst. The suprasellar arachnoid cyst classified as a communicating or non-communicating cyst on a CT cystoscopy. In the non-communicating cyst, the tracer never enter the cyst. The communicating cyst show the early filling and early clearance of tracer. We treated 8 cases of suprasellar arachnoid cyst using the neuroendoscope. And based on the investigation by using MRI and the neuroendoscope, we proposed 2 different types of arachnoid cyst. I mean, a suprasellar arachnoid cyst. Intra-arachnoid cyst of a diencephalic membrane of a Liljeqvist, and cystic dilatation of the interpedicular cyston. The Liljeqvist membrane originates from the dorsum zere and split 2 sheets. The upper sheet, called diencephalic membrane, attached to the mammillary body and separate chiasmatic cyston and the interpedicular cyston. And the lower sheet, called mesencephalic membrane, separate interpedicular cyston and the prepontine cyston. On the basis of the observation of a neuroendoscope, we proposed 2 different types of suprasellar arachnoid cyst. One is the intra-arachnoid cyst of diencephalic membrane, and another one is a cystic dilatation by interpedicular cyston. In intra-arachnoid cyst of a diencephalic membrane, the basilar artery displaced posteriorly, and this vasculature overlaid by a cystic wall. On the other hand, this type of cyst, basilar artery exists within a cyst, and there is no covering membrane of it. This is a case, 6-month-old male with enlargement of head. Prenatal MRI indicate this lesion is congenital. And the MRI show the suprasellar cyst, but you can see the basilar artery displaced posteriorly due to a cyst. And this cyst is non-communicating cyst. So we did the endoscopic ventricular cystostomy. The endoscopy introduced within a cyst. So we can see a oculomotor nerve and basilar artery, but these structure visible beyond the cyst wall, like this. So that we diagnose this cyst as an intra-arachnoid cyst of diencephalic membrane. Another case, 4-year-old male, female with hydrocephalus. And this is a cyst. But you can see a basilar artery not displaced posteriorly. It seems that this artery exists within a cyst. And we did endoscopic ventricular cystostomy. We can see PCOM P1 complex without covering a membrane. So we diagnosed this cyst as a cystic dilatation of interpeduncular cistern. This is another case of a cystic dilatation of interpeduncular cistern. Again, in this case, we did endoscopic ventricular cystosplenostomy. Again, no arachnoid membrane covering a basilar artery and PCA. We can see pituitary stalk, dorsum zelae, basilar artery, PCA here. And the bottom of the cyst, there is a slit valve through which a basilar artery ascends. And we can see open and close. This slit valve open and close in alternative fashion. So regardless of a type of a cyst, the endoscopic ventricular cystostomy work well. Post-operative MRI indicate the marked reduction of the cyst and clinical symptom was improved in all cases. So in retrospective study, neuroimaging and neuroendoscopic observation of 8 cases of supraarachnoid cyst indicates they appear to be divided into 2 etiologically different arachnoid cysts as follows. Intra-arachnoid cyst of diencephalic membrane of Lillekvist, and cystic dilatation of interpeduncular cistern here. So I want to move to endoscopic management of interventricular tumors. Regarding the surgical treatment of interventricular tumors, the choice of strategy depends on the goal of surgery in the specific cases. Number 1, biopsy to establish a tissue diagnosis for more definite chemotherapy or radiotherapy. Number 2, aspiration and decompression of a cystic region. Number 3, complete surgical resection. I think the rule of endoscopy is important in number 1 and number 2, and selected the cases of number 3. Endoscopy can afford less invasive way of reaching 4 objectives. Number 1, endoscopic third ventriculostomy for hydrocephalus associated with tumors. Our experience amount to 20 cases, and success rate was 100%. Tumor biopsy, and we can do a ETV and the tumor biopsy in the same patient. And cyst evacuation for cystic tumors, and tumor removal. I'll show you the case of endoscopic tumor removal. This is a 2-year-old male with a hypothalamic pilocytic astrocytoma. Tumor located within the third ventricle here. Endoscopy was introduced into the right lateral ventricle. This is a foramen Monro here. This is the choroidal plexus. This is a tumor. Using the PAL-1 system, which is an electric magnetic field system, the tumor surface was coagulated. I'm sorry, the halation. Using the glass forceps, the small piece of the tumor was resected. The hemostasis was achieved using the PAL-1 system. This part of tumor attachment so that a small piece of the tumor was left in this area. You can see a pulsation of a basilar artery here. Post-operative MRI indicate the radical resection of the tumor, and as I told you, tumor attached to the left side of the third ventricle, so that a small piece of the tumor was left in this area. So endoscopic removal of a third ventricle tumor require us to introduce endoscopy along the transcortical, translateral ventricle, and transforaminal route. So special care should be paid to avoid the injury of fornix and adjacent veins. Regarding the trajectory approaching to the tumor, it should be changed depending on the tumor location. For example, if we approach to the anterior part of the third ventricle tumor, the bar hole should be placed at the coronal suture. But if we want approach to the tumor in the posterior part of the third ventricle, bar hole should be placed 5 to 6 centimeter precoronal. In addition, I think the use of the fiber scope is mandatory in management of the tumor in the posterior part of the third ventricle. The considering of a surgical risk associated with endoscopic surgery, the enlargement of a ventricle is an ideal condition. However, we can do the tumor biopsy in the patient with the normal size of ventricle. I'll show you one example. This is an 18-year-old male with germinoma in the pineal region. What we did in this patient was bilateral ventricular tapping with the neuronavigation, and extraventricular drainage tube was placed in the left anterior horn with the 20 centimeter H2O setting. And endoscopy was introduced into the right anterior horn, and artificial CSF was continuously injected to obtain enough ventricular size to manipulate endoscope. Under such a condition, endoscopic tumor biopsy was performed. I will show you a video. Again, this is a right foramen Monro. This is a thalamus straight vein here. Now we enter the third ventricle. This is a massa intermedia here. So we try to approach the tumor above the massa intermedia, this space. This is a tumor, and this is a massa intermedia here. Using a glass forceps, the small piece of the tumor was resected. Another piece of the tumor. Almost 10 pieces of the tumor were obtained with this procedure. At the end of the surgery, you can see a minor injury of a fornix here. Fortunately, this injury of a fornix resulted in no adverse neurological consequence. The endoscopic tumor biopsy was followed by one course of chemotherapy. At that time, the tumor was already disappeared, and you can see a trajectory of a bilateral ventricular tapping. I think the brain injury are very much minor. So in conclusion, hydrocephalus associated with the posterior host and the posterior subventricular tumor can be successfully managed by endoscopic third ventricular stomy. This is a case of medulloblastoma. The patient came as a drowsy state in the evening. So we did not want to do the tumor resection in the midnight, so we did endoscopic third ventricular stomy, and the patient's condition is recovered. 3 or 4 days later, we did tumor resection under the craniotomy. And the endoscopic cyst evacuation is a useful technique in management of interventricular cystic tumors. We like to do this procedure for recurrent cystic craniopharyngioma, so that in the most of cases, endoscopic cyst evacuation was followed by radiotherapy. Endoscopic tumor biopsy. Several biopsy specimens can be obtained, identify the tumor which will require the further craniotomy or adjuvant chemo and or radiotherapy. Endoscopic tumor biopsy is possible in the case with a normal size ventricle using the bilateral ventricular tapping technique I described in this paper. Endoscopic tumor removal. Small, less vascular tumor causing the enlargement of a ventricular system by blockage of CSF pathways represent an ideal indication for endoscopic treatment. But solid tumor should not exceed 2 centimeters in diameter. Thank you very much for your attention.
본연제에 대해서 질문이나 코멘트 하실 분 한 10분 정도 10분 좀 넘습니다. 디스커션 시간이 충분합니다. 네, 닥터 왕.
I'm Dr. Wang, Seoul National University. Thank you for your nice presentation. I would like to make a comment on the ETV, endoscopic third ventricular stomy, with the craniofacial reconstruction. The case was around 13 years old boy who has a large head because of hydrocephalus already. And I did the ETB to control the hydrocephalus initially. Initially, the result was good. Reduction of the ventricular size, enlargement of the cistern and sulci, that's okay. But one month later, about 1 month later, I did reduction cranioplasty, and I fixed the bone with many wires. After reduction cranioplasty, the ventricle, the size of the ventricle is getting bigger and bigger, and finally I had to put the shunt in. I would like, do you have a similar experience on that?
I have had such a case, but probably a reduction of a cranial bolt, reduction of the size of a cranial bolt may result in the disturbance of CF circulation and patency of subarachnoid space. That is the reason why the hydrocephalus developed after the cranial reconstruction.
Yes.
I guess.
That
But,
may be one reason, and also for the functioning ETV, I think some rigidity of the cranial bolt is necessary. Maybe that would be another explanation.
Yeah, maybe.
And I would like some questions. You showed the case with the bilateral unilateral EVD and ETV through the other lateral ventricle to enlarge the foramen of Monro. What do you think about just insert the endoscope only with irrigation? But in that case, we have to close the outlet of the irrigation. Then we can apply some amount of pressure. Then we do not have to insert EVD into the other lateral ventricle. What do you think about that?
I'm just concerned with the increase of intracranial pressure due to the injection of artificial CSF, so that the ventricular drainage is safety for to prevent the raised intracranial pressure.
I sometimes use that method to enlarge the ventricles and sometimes stop bleeding. In that case, I limit the height of the water bag within 20 centimeters, 30 centimeters to limit the amount of increased ICP. I suggested.
Yeah, probably an alternative way, yeah.
Recently, the endoscopic surgery for the hypothalamic hamartoma is one of the topic.
Yeah, right.
What do you think about that?
Yeah, I'm sorry, I have no experience the endoscopic surgery for hypothalamic hamartoma, but it seems to be a work. I think that if I have a patient, I'll try to do it.
Thank you very much.
네, 다른 코멘트나 질문 없습니까? 거의 한 10분 정도 디스커션 시간이 충분합니다. 우리 정윤남 선생님 뭐 퀘스천 없어요? Yeah, I have some questions. In your procedures for suprasellar arachnoid cyst, do you do only superior part of the cystic membrane opened, not in the inferior part of the arachnoid cyst?
Yeah, I did ventricular cystostomy in most of cases, and in some cases I did ventricular cystocystostomy. That means that we make a hole the bottom of the chest. And a few years ago, I discussed with Dr. Pierre Kahn which is better. I mean, cystocystostomy or ventricular cystocystostomy or ventricular cystocystostomy. He said there is no difference. So that I changed my mind, and because the risk associated procedure will increase with the ventricular cystocystostomy. So two procedure. So that now we do the ventricular cystostomy, and just observe the bottom of the cyst.
Thank you. And then the other questions, in your procedures for arachnoid cyst, particularly middle process arachnoid cyst, how much you open the arachnoid membranes into the cystons? How many places, or what is your tactics to communicate the cyst with the cystons, supracellular or subthetic?
I try to make many hole as much as possible, but usually 2 or 3, in order to avoid the injury of third nerve and
Yes.
vascular structure. So that usually 2 or 3 hole the maximum.
That was usually successful,
Mhm,
right?
mhm.
Is how much is the openings?
I try to make a 3 millimeter.
3
in
millimeter.
diameter.
Yes. Okay. In the shunt dependencies programs, how many cases did you have experience in the shunt dependencies in generals hydrocephalus due to by the arachnoid cyst, particularly in temporal lobe arachnoid cyst? You all
I
almost
should-
all successful, so you may not have any.
Yeah, but as I mentioned in my presentation, I had 4 cases of shunt
cases.
dependency, and that is a really real serious problem for patient and for doctors, and it's a fatal complication, I think. So that now we try to treat the arachnoid cyst using the endoscopy first, and see the patient, and if necessary, we put in a shunt.
In what cases did you try arachnoid cyst penetrations as well as cystoperitoneal shunt? You don't have any experience both of them in one settings.
So that, as I told you, I do the endoscopic cystocystostomy at first, and see the patient, and if patient does not improved in symptom, and the cyst reduction is less than 50%, I do put in a shunt.
So you didn't do a simultaneous
No,
cyst?
no.
Okay. 우리 충남대학의 송 교수가 어디 안 보이는데, 뭐 무슨 퀘스천이나 뭐 코멘트 하나. 예.
Thank you very much for your lecture. I'd like to ask one question about you. What is your policy nowadays for malfunction hydrocephalic patient who had architectural stenosis? Before we use endoscopic third ventricular stomy, we had to put in shunt catheter into the ventricle to treat architectural stenosis patient. Nowadays,
some authors recommend endoscopic third ventriculostomy rather than shunt revision. What is your
So if we can see
recommendation?
the ventricular dilatation,
Yes.
I do the third ventricular stomy first and take out the shunt. And of course, the close observation after the surgery is mandatory.
How many cases did you have the case?
Maybe 30, about 30 cases.
Okay.
Yeah.
Is there no questions or comment? I have a last questions. In the multiple loculated cyst, probably caused by infections, have you ever tried to fenestrations to make one ventricle like that?
Yeah, that is a very difficult case, and I did make one space using the endoscope
yeah.
and then put in the shunt.
Yeah.
That is, I think, best way to treat such a case.
네, thank you. 없으면은 지금 한 4분 남았지만 어디 no other questions? Thank you very much.
Thank you.
조금 이따가 할까요? 아니면은 지금 곧 이어서 하는 게 좋겠죠? Next topic is about lipoma, spinal lipomas, lumbosacral lipoma. He has, as I said, many experiences about lumbosacral lipomas. Yeah,
Okay.
please, yeah.
I will second topic I present is the surgical treatment of lumbosacral lipoma. And lumbosacral lipoma is the most common lesion in the occult spinal dystrophism. Various stigmata are present in the majority of patients, and tethering by the lipoma to the spinal cord result in the risking progressive neurological disability. This afternoon, I would like to talk about the classification, embryogenesis, surgery, and finally I will discuss indication of a surgery for asymptomatic patient. Chapman classified the lumbosacral lipoma into three groups: caudal type, dorsal type, transitional type. In a caudal type, the lipoma attached to the caudal end of the spinal cord, and according to Chapman, some nerve root pass through the lipoma. In a dorsal type, lipoma attached to the dorsal aspect of the spinal cord, and the nerve root exists always ventral to the junction between the lipoma and the spinal cord. In a transitional type, lipoma attached to the caudal and dorsal aspect of the spinal cord, and some root pass through the lipoma. But with the accumulating of my experience, we realize that there is some lipoma cannot be classified by Chapman classification, so that we propose a new classification of a lumbosacral lipoma. Those are the dorsal, caudal, combined filar type lipoma and lipomyelonmeningocele. Dorsal type, caudal type, combined type of our classification are equal to dorsal, caudal, transitional type of Chapman classification respectively. In a filar type lipoma, the Rosette conus was tethered by swollen film terminale with the lipomatous tissue here. In a ribomyelonmeningocele, spinal cord protrude outside the spinal cord and enter the subcutaneous meningocele and the terminate, attached to the lipomatous tissue of meningocele wall. Paying attention to the surgery and its result, some authors believe that the most useful clinical distinction is between the lipoma of the conus medullaris and the filum terminale. Lipoma of conus medullaris comprise 74 to 87% of lumbosacral lipoma. In this type of lipoma, we can see always dorsal-dural defect through which the lipoma penetrate. And lipoma always involved neural tissue, including the spinal cord and nerve root. On the other hand, lipoma of the filum comprise 13 to 26% of lumbosacral lipoma. And we cannot see the dorsal-dural defect in almost all cases. And the lesion is basically intradural, and lipoma limits to the filum terminale and does not involve neural tissue. This is an intraoperative photo of lipoma of the conus. As I told you, we can see a dural defect here, and lipoma penetrate the dural defect and attach to the spinal cord. This is a junction between the spinal cord and lipoma. Because of the existence of dural defect, the duroplasty is necessary at the end of the surgery. This is a lipoma of a filum. As I told you, there is no dural defect. Dura is intact here. And the lesion is basically intradural. And the lipoma limit to the filum and does not involve the neural tissue. And this is a postoperative MRI. So filler type of lipoma in our classification is equal to lipoma of a filum. And the other 4 types of lipoma are included in the lipoma of the conus. Embryogenesis. I want to briefly review the formation of a neural tube. Anterior neural pole closed during the period between the 23rd and the 25th post-ovulatory day, and the posterior neural pole closes between the 25th to 27th post-ovulatory day. With the closure of posterior neural pole, the primary neurulation is completed and the anterior neural tube is formed. Following the completion of primary neurulation, multipotent cell cluster called caudal cell mass appear just caudal to the anterior neural tube. From these caudal cell mass, the posterior neural tube is formed and fuses with the anterior neural tube. And the posterior neural tube give rise to a tip of conus medullaris and filum terminale through the process of regressive differentiation. And these processes are called as secondary neurulation. So that the various pathology of spinal dysplasia can be divided 2 groups. One is a disorder of a primary neurulation, and another one is a disorder of a secondary neurulation. And disorder of a primary neurulation include mielomeningocele, lipoma of the cornus, dermal sinus, and the split cord malformation. And disorder of secondary neurulation include a lipoma of Hilm, terminal myelocystocele, and a thickened film terminale. For example, the primary neurulation stop at this stage. We can see a mielomeningocele. So regarding the embryogenesis of lipoma of the cornus, Macron and Neidig proposed a premature disjunction theory. According to their theory, the whole neural tube prematurely detached from the ectoderm, and this allows the mesenchymal tissue access the prospective lumen of a neural tube here, and this ingrowth of a mesenchymal tissue prevent further closure of a neural tube, so that this part of a spinal cord is a state of a dorsal myeloschisis, so-called placard. Regarding the embryogenesis of lipoma of the film terminale, the impaired regression of process of a caudal cell mass and persistence of cells capable of maturation to adipocyte are likely to be involved. So that in a lipoma film, the spinal cord is developed almost normal fashion. So we can see a normal configuration of a spinal cord in the case of the lipoma of the film. Surgery. The importance of a sagittal section of MRI is undoubted as a preoperative neuroimaging of lumbosacral lipoma. For example, in this case, Rosette cornus is tethered by a lipoma, and a large sphinx is evident. In addition, I think the three-dimensional CT of a dystrophic spine gives us a lot of information, especially those information useful to make a surgical planning. The sagittal section of MRI help us to understand the gross anatomy of a lesion, but the axial section of MRI gives us a more detailed information. For example, in this case, axial section at S1, S2, S3, and S4 show the junction between the spinal cord and the lipoma rotate on the axis. And this type of information is very, very important to avoid injure the neural tissue during the surgery. There are several steps in the surgery, and one of the most important steps of surgery is to identify the normal dura, the rostral to the lesion. For this purpose, laminectomy or laminotomy is necessary almost all cases. Following the amputation of a subcutaneous lipoma, dura is open, and the meninges and lipoma are dissected completely at the junction with the spinal cord, and then the lipoma is amputated at junction with the spinal cord. Some cases associated with the thickened film terminale and the terminal sphinx, so that in those cases, the amputation of a thickened film terminale and Sphinx subarachnoid node shunt are required. And we try to reform the spinal cord with the closure of pi RH if possible. At the end of the surgery, duroplasty is performed using the Gore-Tex sheet. I will show you a video. I prefer the midline straight incision. This is a rostral, this is a caudal side. The cutting the subcutaneous lipomatous tissue. This is a subcutaneous lipoma already amputated. This is L5. So in order to identify the normal dura, the laminotomy was performed. So this is a normal dura, and this is a dura defect through which a lipoma penetrates. This is a normal dura, and this is a lipoma here. Dura is open. And meninges and lipoma are dissected at the junction with the spinal cord. The left side of lipoma, the caudal side, caudal side, so we try to confirm that this strand can be cut using the neurostimulator. Now the untethering procedure is completed. The neurostimulation. Now the lipoma amputated at junction with the spinal cord. Now we try to deform the spinal cord with the suturing the pi RH. This is a deformed spinal cord. And finally, duroplasty is performed using the Gore-Tex sheet. I'll show you next case. Actually, the tethering due to lipoma was already released. And I want to show you the thickened, associated thickened hilum terminale in this particular case. This is a thickened hilum terminale. This one. Nervous stimulator. And cut. So that this procedure is very important in the case with the thickened hilum terminale. So if we look at the associated anomaly in 144 lipoma cases in our series, thickened film terminale found in 28 cases, and terminal shrinks in 24 cases. So that in these 28 cases, the amputation of a thickened film terminale is required. Regarding the shrinks, it's a very difficult issue. Its incidence is reported to be 2.5% to 10% in the literature. But the relationship of shrinks to patient symptomatology is unclear, and surgical indication is controversial. Chapman Farm reported 3 cases of symptomatic syringomyelia, which occur de novo following an operation to relieve detethering of a previous treated spinal lipoma, and successfully treated them with syringo subarachnoid shunting. But still, it is not unclear how to manage the shrinks diagnosed before the first antethering surgery. I do a SS shunt for this size of the shrinks, I mean a large size of shrinks. But we do not do the SS shunt for small shrinks because small shrinks disappear sometimes following the antethering surgery. So finally, I will discuss on the surgical indication for asymptomatic patient. Surgical intervention for a symptomatic patient is generally accepted. However, that for asymptomatic patient is controversial because natural history of this disease not clear, and there is some risk with the antethering surgery. So in order to draw a conclusion in this matter, I reviewed my series. We surgically treated 144 patients with lumbosacral lipoma, including the 62 asymptomatic cases. Neuroimaging showed the Rosette cones in all cases, and we classify lipoma into 5 types, as I described. The patient was evaluated pre- and post-operatively using the clinical grading scheme by Dr. Hoffman. Grade 0 is asymptomatic, and grade 5 is the most severe case. This is 5 types of lipoma, as I mentioned. The number of the patients of each type of lipoma are shown here. Dorsal 59, caudal 28, combined 30, filar 9, lipomyelomeningocele 18. And the surgical procedure basically is same in various types of the lipoma, except for the filar type lipoma. This is one of the examples of how the spinal cord migrates ventrally following the surgery. And you can see the small shrinks disappeared spontaneously following the antethering surgery. Left side also the good example of successful antethering surgery. But with accumulating experience, we encountered this type of case. In this case, post-operative MRI continues to show the certain amount of lipoma, and we cannot see enough shear space surrounding the lipoma. So in a for example, in the combined type lipoma, the nerve root penetrating our intermingle with the lipoma. So such a anatomical characteristic prevent satisfactory untethering surgery. So each type of lipoma show the respective surgical anatomies and indicate a different surgical difficulty. So lipomyelonmeningocele and the combined type lipoma, anatomical surgical anatomy is complicated and the surgery is difficult. The Cowdell type lipoma and the Filler type lipoma, anatomy is simple and surgery is easy. So how does this fact affect on the surgical result? I will show you my surgical result in 144 cases. During the follow-up period of 9.9 years, there are no neurological deterioration in most of cases. And some cases have even improved in a function. However, these 13 cases show the post-operative neurological deterioration. Out of the 13 cases, 2 cases show the immediate neurological deterioration, and 11 cases show the late neurological deterioration. Immediate neurological deterioration considered to be directly related to the surgery. And these 2 cases, the combined type, as I mentioned, the combined type is anatomy is complicated and the surgery is difficult. So that surgical difficulty of this lesion must be related to the immediate neurological deterioration in these 2 cases. On the other hand, late neurological deterioration is due to retethering and or sphinx formation. But we cannot see type specificity in these late neurological deterioration cases. I'll show you one of the examples of the symptomatic retethering. This is a 4-year-old boy. Originally, he had a Cowdell type lipoma. And the untethering surgery was performed because the patient developed progressive bladder dysfunction and lumbar pain. And the duration between the initial procedure and the reoperation was 39 months. This is a MRI after the first operation, before reoperation, and after reoperation. This is a intraoperative photo. Under the Gore-Tex sheet, there was a dense fibrous membrane, which is a cause of the retethering. So I want to say you the use of a Gore-Tex sheet cannot prevent retethering of the spinal cord. So if when we discuss the prophylactic surgery for asymptomatic patient, the immediate and late neurological deterioration should be evaluated critically. Pierre Kahn indicates that there were 2 different types of lipoma: lipoma of the film, for which surgery was harmless and beneficial, and lipoma of the conus, for which surgery involved considerable risks and was questionable benefit. Chapman also indicates that prophylactic operation was recommended in the cases of dorsal and caudal type lipoma according to their classification, but not in the cases of a transitional type. Regarding the late neurological deterioration, Korak reported that the 19 patients present symptomatic retethering, and patients with transitional lipomas had a significantly higher frequency of symptomatic retethering than those with the caudal and dorsal region, according to the Chapman classification. So I think there are two different patient groups of lumbosacral lipoma. Group 1, caudal, filler type lipoma, and most of dorsal type lipoma, according to my classification, in whom the surgical anatomy is a simple and satisfactory untethering surgery could be done without risk. Group 2, combined type lipoma and lipomyelonmeningocele, in whom surgery would be accompanied with some risk, and sometimes complete untethering could not be achieved because of complicated anatomy of the lesion. So surgical difficulty of group 2 can be correlated with the increased frequency of neurological deterioration occurring just after the operation. The concerning prophylactic surgery for asymptomatic patient, group 1 of patients are obviously good candidate, but group 2 is not. Thank you very much for your attention.
예, 이 서브젝트에 대해서 코멘트나 아니면 퀘스천 있으면 받겠습니다. 라이포마 시리즈로서 144例 같은 상당히 많은 케이스입니다. 세계적으로도 그렇게 발표된 게 별로 없습니다. 그래서 물론 맥론의 시리즈는 물론 많지만 이 정도 시리즈라면은 세계적인 시리즈입니다. 예, 닥터 왕.
I want to make a comment on the premature disjunction theory. A few years ago, we published a paper. In that paper, initially we insist on unilateral neural fold at the distal part of the still unclosed neural tube in chick embryo. A few days later, we harvested the embryo and make a pathological section, histological section, and we could see some evidence of the lipoma-like malformation. Those are lump with the indistinct basement membrane of the neural tube, or blending of the mesenchymal tissue with the neural tube. That is my comment. And in some case, on the actual MRI of the lipoma, the intraspinal lipoma continues to the intervertebral foramen. In that case, we know that complete untethering is impossible. Do you still recommend surgery in that case?
No. You mean the lipoma extend along the nerve root?
Yeah.
Into the intervertebral foramen?
Yeah.
I think it is impossible to do satisfactory untethering surgery, so that
Therefore,
if patient is asymptomatic, but the problem is that if patient is symptomatic,
symptomatic,
what do we do?
even though you expect incomplete untethering, you do the surgery
I do.
as much as possible.
Yeah, right.
Okay. In some case, even though the patient is neurologically intact, I mean, no neurological deficit, but there is a huge bang mass. What do you do in that case? Just liposuction or do the untethering?
I will observe the patient without surgical intervention.
Even though there is a large bang mass here?
I try to. I explain the parent and try to observe the patient without surgery.
Observation. Okay, thank you.
다른 퀘스천 없습니까? 있어서.
Thank you for your lecture. In order to diagnose or suspect of retethering of lumbosacral lipoma patient to myelomeningocele patient, clinical feature or newly developed neurological deterioration is more important than radiological findings, because radiologic finding is unbelievable. Usually, many patients didn't ascend even after untethering of lumbosacral lipoma or myelomeningocele patient. My curiosity is, what is your average ascending level of conus medullaris, end of conus medullaris after untethering? What is, how much level usually ascend after untethering?
In the most of cases, I do not see the conus medullaris ascend. But the conus medullaris and the spinal cord migrate ventrally, not ascend. That is the ventral migration of spinal cord, I think, a good indicator of the satisfactory untethering surgery. I don't care the level of the conus.
Conus medullaris. Thank you.
다른 퀘스천 없습니까? I have some questions. First, about dural repairs, you used the Gore-Tex. In the past, the elastic, the elastic material was used, but it was many sclerosis and some calcifications. It was abandoned. Do you know any other newer agent, newer materials to prevent? You don't have any information
no.
about it?
I really hope that we have a new material which can be used for duroplasty, because as I show you, the use of Gore-Tex cannot prevent
Yes.
untethering, so that retethering, so that. But I don't like use the fascia lata of the patient. So there is no good material can be used for duroplasty at present time.
And second, I saw not so small portions. Just many times I had an experience of thickened nerve root in the spinal, in the dura, without having any fatty tissues. Just the dorsal or transitional lipomas is here, and the outcoming root are thickened and short, and tetherings was evident by that roots. In those cases, how do you handle the roots? If according to the monitorings you can divide or not, what is your criteria to handle that?
As long as the neurostimulation does not present any response of on the EMG, I cut.
So you have a EMG positive, you don't
Cut.
resect. But if not, you can resect.
I think so.
There was a big dilemmas in the
Yeah, right.
resecting
Right.
that
I
one.
know.
Yeah.
Yeah.
And in my experiences, lipomyelomeningocele compared with the other lipoma, is the proportion is not so common and not so different in proportions. But in your this 144 cases, I didn't remember exactly the numbers, but you showed us this lipomyomeningosis is some very rare, or 18 cases over 144, right?
Yeah.
It's quite very small proportions of lipomyomeningosis, I think.
So you have more
Than
cases.
yes, about my personal experience. Not I didn't classify that exactly. The analysis was not done, but my experience was about 30 or 40 case, 40%
I see.
was lipomyomeningosis. It's
That's interesting.
what Professor Wang, what is your experience?
I think my series has almost similar figures
Similar.
like that.
Oh. At the initial stages, I was impressed as a very common in myeloma.
I'm happy with the small number of the lipomyomeningosis because surgery is difficult
Yes.
in those cases.
Yeah. Did you any difference between the lipomyomeningosis and usual lipomas in type of you are according to the classifications? Which one is this type, or which one is more common in these types? Do you have any difference between the lipomyomeningosis and other dorsal caudal combined types? Lipomyomeningosis, how do you classify? Is it dorsal types, caudal types? Is no relationship
No,
between
no.
just
Mhm.
lipomyomeningosis. Okay. Okay. We have more times, but if there is no questions or comment, I would close these sessions. Thank you very much.
Thank you very much.
Professor Hajime Arai, Professor and Chairman, John Tendo University. On behalf of the Department of Neurosurgery at Seoul National University, I take great pleasure in presenting you this letter of appreciation in acknowledgement of your excellent lecture given on March 19th at the Symposium Neurosurgery Update 205. Hyewon-jung, Professor and Chairman. Thank you.
끝까지 경청해 주셔서 감사합니다. 마지막으로 그 정의원 교수님으로부터 끝내는 말씀이 있으시겠습니다.
예, 늦은 시간까지 감사합니다. 내년 3월 셋째 주 토요일 날 똑같은 뉴로서저리 업데이트 코र्스가 있습니다. 근데 내년엔 지금 조금 형식을 조금 달리 해볼까 하는 걸 연구 중에 있습니다. 그래서 금요일 날 토요일 날 이틀 할지 지금 계획 중인데요. 라이브 서저리를 하루쯤 하고 하루는 렉처를 듣는 그런 것도 지금 생각을 해보고 있습니다. 내년에 또 많이 와주시기로 부탁드리고요. 오늘 대단히 감사합니다. 안녕히 들어가십시오.